So this is the first case, and today we don't have a case presentation particularly. Can somebody go over the radiology, or is everybody in the Sunday mode?
If no one is available, that I can.
Yeah, Dr. Mustafa, I'd be glad if you can.
Uh, 51A. This is the axial cut
Mm-hmm.
CT scan brain showing hypodense area at the level of the left parietal lobe, ma'am.
No, it's occipital. It's almost occipital lobe.
Occipital vein.
Yeah.
51B is the
Yeah, it's the same lesion corresponding to the same location. This is homogeneously hyperintense, and it does not create any sort of mass effect if you see here, and we don't see vasogenic edema around, but the lesion is completely homogeneously hypointense, and it's
51C is the diffusion weighted image.
yeah, five
The
five one C is flare.
flare
Yes,
image.
5-1-C is flare.
It's the hyper intense rim with the
Yeah,
hypo intense central area.
yeah. What is that called?
This is called the T2 flare mismatch.
Yeah, I am sure everybody who has been attending these sessions or watching the recordings would be very clear of what T2 mismatch is, because we do see it in gliomas. But here, this might be misrepresentation. Let's not stay stuck on the radiology today. Moving on, what do you see in the sagittal section?
This is the sagittal cut of the MRI
Okay.
showing the hypo intense lesion at the level of the occipital lobe.
Okay, and do you see any contrast uptake?
No, ma'am.
Okay, so no presentation today because I figured it would be very easy for all of you to gauge that this was a diffuse low-grade glioma. This is the last one of the low-grade gliomas among pediatric pathologies that we are going to do, MAPK pathway altered. They are interesting because I find them like chameleons. They are tumors which sometimes resemble pilocytic astrocytomas, both molecularly and histopathologically, sometimes even on radiology as well. But these are diffuse, piloastro are well circumscribed. So they are different classes. These are the chameleons. They are IDH wild type, H3 wild type as well. And if you see just this molecular profile, this might look like the a typical high-grade lesion, but we have learned enough to say that when we find this, we look for other mutations and other molecular profiles, especially the pediatric profile. So these are IDH wild type and H3 wild type. They are still grade 1, and there is absence of homozygous deletion of CDKN2A. These are WHO grade 1 tumors. There is certain overlap with pilocytic astrocytoma on molecular level, but these are diffuse instead of well circumscribed. And they can occur anywhere in CNS. They can be found supratentorially, they can be found infratentorially, sometimes even in the spinal cord. And the presentation is varied. Presentation depends on the location of the lesion. It might present with raised ICP symptoms, with visual deficits, with mass effects, with seizures, and some of these have syndromic association as well, NF1. So these are the molecular drivers. And why are they important? They are important because when we find these mutations or these fusions, we can give them targeted therapies. And molecular drivers are BRAF fusions. These are the most common alteration. They are a significant overlap with pilocytic astrocytomas. There is BRAF V600E mutation. There are NF1 mutations which are associated with NF type 2, type 1. We have FGFR1 mutations in fusions, and we are later going to see the role of them. So surgery stays the gold standard treatment. The GTR is still gold standard. If you get them out completely, the complete removal is curative. And the targeted therapy that I was talking about is BRAF inhibitors. dabrafenib, specifically for BRAF V600E mutations. We have MEK inhibitors, selumetinib, trametinib. These are effective for BRAF fusions and NF1 related tumors. So, when do we use these targeted therapies? Does anyone have any idea?
Especially when we want to temporize the disease.
Okay, Dr. Mustafa, I think you're mixing this up with the IDH blockers, the IDH inhibitors, vorasidenib.
Yes,
Yeah,
Porcidanil.
yeah, no. This is not vorasidenib. This is not a temporizing measure. Yes, you can use them as temporizing measures as well. We use them when we have done subtotal resection. There is tumor still there, and we use BRAF inhibitors or MEK inhibitors to control the tumor volume. So these are not exactly used as temporizing measures, but they have a very good response if the tumor is in a location where we cannot get it out completely, and either the location is eloquent or it is very difficult to access. So, chemotherapy and radiation, there is still some role of traditional chemotherapy. Carboplatin and vincristine, the PCV based chemotherapy, that is still used, but radiation is avoided whenever possible due to long term neurocognitive risks in developing brains, since we know that these are pediatric tumors. And that was it for the low grade gliomas. We start the diffuse high grade gliomas from today. This is the first one. I'm sure a lot of you would be knowing what this is, but I would really like if somebody can volunteer and explain the radiology. Anyone? This is a very easy one. No? Okay, Dr. Kingsley.
Okay, thank you. This is a T1 with the image of MRI. That's the axial view. I can see a hypo to isodense lesion within the pons that seems to be expanding the pons outwards, both anteriorly and posteriorly.
Yeah, that's right.
That
We
I can
have a
see.
hypo to isointense lesion here, which is expanding the pons, which is also diffusely involving the pons. And moving on to the next image, what do you see here?
It's hyperintense on T2.
Yeah, this is hyperintense on T2, and we can see that some portion of basilar artery is also getting encroached on it. And this is again diffusely involving the entire pons. This is flare, our pretty T2 flare mismatch sign, but that does not have any prognostic significance in this type of pathology. So these are diffuse midline gliomas, H3K27M altered, previously called brainstem gliomas, sometimes thalamic gliomas, sometimes diffuse intrinsic pontine gliomas. What happens is this particular alteration, it leads to the cell in a locked situation. The cell is locked in an undifferentiated, rapidly dividing state. It keeps on dividing, and the dividing cells are completely dedifferentiated. So, what ends up happening is a very highly aggressive, highly malignant WHO grade 4 tumor. The location is always in the midline, the brainstem, especially pons, thalamus, spinal cord, primarily involving children, but it might present in young adults as well. You might see them in 18, 19 years old. I recently saw a patient who was 23, 24 years old with bilateral thalamic glioma. And the course of the disease is very short. We are not talking about months here, we are talking about weeks. The patient usually cannot wrap their hand around what just happened to them because the deterioration is very quick. And often at presentation, there is already leptomeningeal involvement, because they do have CSF seedling. Therefore, when you find a midline lesion, a midline glioma, always get the imaging of entire craniospinal axis to rule out any drop myths. So, as I said, the presentation is rapid onset, weeks, not years of the classic triad. If it is brainstem, we are looking at multiple cranial nerve palsies, long tract signs, and ataxia. Patient might have double vision, patient might have facial droop, there might be weakness in arms or legs, hyperreflexia, positive Babinski's. We might have ataxia, which is clumsy gait or imbalance. So, what are the current trends? Because this is a topic of huge debate, especially uh, sometimes during exams or during rounds. If the one asking this question is from the old school of thought, they are going to propose that since we cannot do much by operating or by taking a biopsy, so the good old thing to do is diagnose by the image and send these patients to radiology, only managing hydrocephalus if patient is presenting with hydrocephalus as well. But what are the current trends? The current trends show that the old diagnosis by imaging alone is now largely discouraged in recent literature. Stereotactic biopsy is the new standard of care. If your setup has a stereotactic biopsy, you do it. If it does not have it, then you refer the patient to a setup which has a stereotactic biopsy. And I know this is not practical or feasible for a lot of us who are working in public setups. There is another development which has been very recent, especially 2025 and 2026, the concept of liquid biopsy. Well, this is not standard or guideline based right now. This is still in development. Concept of liquid biopsy is the same. You get out a sample of CSF and detect circulating tumor DNA in it with the help of PCR and stuff. And if that is positive, then that means liquid biopsy for this tumor is positive, right? Are you with me so far?
Yes, ma'am.
Yes.
Okay. So, what else is happening? Radiomics. Radiomics is really playing a huge role in the diagnosis of the lesions, which are not easily accessible by the biopsy, because at the end of the day, biopsy is still an invasive procedure, right? You are going to take out a biopsy from the brainstem. That's not a laughing stock. So, radiomics bridges that gap. And there are already very successful models using T2 and FLAIR and diffusion weighted images. What they do is they take up microsections and then they predict H3K27M status with 80 to 90% accuracy before a needle ever touches the brain. So in 2026, we are looking at 80 to 90%. Maybe in a year or two, this is what would become the gold standard, diagnosing them with the help of MRI and radiomics instead of stereotactic biopsy as well. So, why biopsy? Does anybody have any idea why we are advocating biopsy here?
Because it is a very sensitive area and sudden death or table death can occur.
Yeah, but if that is such a sensitive area, why are we advocating biopsy? Yeah, Dr. Lalita is saying because of targeted therapy. And there's another one, mutational status, histological diagnosis. That's right. We need histological diagnosis. That's one thing. Also, we need to see the mutational status. There are certain mutations that improve the prognosis, then there are certain mutations that worsen the prognosis even further. Also, when we have the tissue diagnosis, we can tell the patient whether they are eligible for clinical trials or not. And I understand that a lot of LMICs don't have clinical trials running in their neurosurgical setups or neuro-oncological setups, but the setups that they have, those they are the birthplace for all the new research, all the new responses. So, any patient which is eligible for a clinical trial should undergo clinical trial. And you cannot send them to clinical trial without a biopsy. What happens after the biopsy? after we know that this is S3K27M altered pathway, radiation is the standard treatment. Total dose is typically 54 to 60 grays. 54 grays is common for tumors in the brainstem. And if you're talking about bithalamic involvement or spinal cord involvement, then 59.4 to 60 grays might also be used. And these are given in fractions, 1.8 grays per day, given 5 days a week. And duration is approximately 6 weeks. Targeting is 1 to 2 centimeter margin around the tumor. Whole brain radiation is not standard for the midline gliomas anymore. Photon therapy is more common, what we have easily available in a lot of the radiology setups. But proton therapy, even though it's less commonly available, but it is safer in children and reduces the radiation exposure to rest of the brain. So, what is the prognosis? We all know that despite a lot of advances, we are still not very successful in terms of treating the diffuse midline gliomas. Thalamic tumors have slightly better prognosis, roughly around 14 to 18 months compared to pons. The pontine location is notoriously very, very poor in terms of prognosis, and spinal locations might also be poor in terms of prognosis. And we know the notorious mutation TP53. If this is present, this just means that patient is going to have an even shorter survival because there is going to be increased resistance to radiation and a shorter survival rate. So the typical age group is 5 to 9 years, but if the patient is under 3 or if the patient is older than 10, they have slightly better prognosis. Young adults have even more better prognosis. What you see here is, let me go back to the previous slide. Just give me a minute. This is the previous slide. This. So what you see here is a range 14 to 18 months. Usually patients with pontine gliomas and who are in the typical age group, they have a survival rate of around 6 to 7 months. The longer spectrum is what shows the locations in other regions, for example, spine, for example, thalamus, and the atypical age group, which is younger adult, 1920s, this age group. So that's a wrap. Any feedback, any question, all of that is welcome. Monday, we are wrapping up pediatric high-grade gliomas, inshallah, and then let's see what we will proceed with. Any questions, any feedback?
Thank you, ma'am. Bundle of thanks, ma'am. This is a wonderful session, and especially the motivation at the start of the lecture that you give us. It's really, really mean for us.
Yeah, I really hope that all of you would go back, read up on these, and also reassess yourself where you are standing, because we might end up becoming good clinicians, but the road to be extraordinary is different. It's a lot more different. I think that's enough of the motivation for today. Let me know if you have any questions in terms of the topic.
Is today the radiology topic should be occur or not, ma'am?
Radiology, yes, we are going to plan the radiology session again. Probably on Fridays. I have to coordinate with Dr. Itazaz. It's just that the internet was really, really bad last week. This week, hopefully, is going to be better, inshallah.
Inshallah.
Hi, doctor.
Hello, Dr. Lalita. Yeah.
Yeah, regarding the H3K27M, is
Mhm.
that a radiological study or that's a molecular study?
No, H3K27M is a histological, a molecular diagnosis. You need a tissue sample and then you
Right.
need to run the molecular profiles, see if
Uh-huh.
H27KM pathway is altered. And we are using the word altered because sometimes there are other mutations which mimic the same pathway, but they are not actual mutations in H3K27M. But that was a lot of molecular profiles. I did not want you people to be bored, so I did not go in the details.
So I just want to ask back regarding one of the slides that you mentioned.
Mm-hmm. Which slide? Dr. Lalita, you're not
Oh,
audible.
sorry. Regarding radiomics, there was a slide on the
Yeah.
radiomics just now.
Yeah, this one.
This one. So, doctor, here the radiomic model using T2 flare and DWI can predict this H3K.
H3K27M. Yeah.
So even without biopsy,
Yeah. Even without biopsy.
Oh, this is nice. This is
Yeah,
interesting.
this is nice, and this is going to be life-changing for the patients, because if you see it from a family point of view, if somebody's child is not going to get benefited from a surgery, why would they agree, or why would they agree to subject their family member to that surgery? Because what we are offering them is not a hope for the cure. We are putting a child through our invasive procedures just because we want a tissue diagnosis. So if radiomics if it becomes widespread, which it would in a few years, then this solves a big problem, because you get a diagnosis without being invasive.
Yeah, correct. This our oncology colleagues would have to agree to starting the therapy without the tissue biopsy.
Yes, they would.
Yeah.
It might even become a part of guidelines in the coming few years.
All right. Okay. Thank you, doctors. This was interesting. Yeah.
Okay, everyone. So